We're going to get ready for our final presenter. And we're going to have Caitlin Johnson come up. Caitlin Johnson is going to do the next introduction for our last speaker. And we appreciate you coming up, Caitlin.
They saved me for last because I'm loud. So, gotta wake us up. I am very excited to introduce our next speaker. We've got to spend some time with him and his business partner, Dr. PJ, and it has been a whole lot of fun. So I'm going to go ahead and introduce Dr. Onugha, and then I will hand it over to him so he can fill us all in on different modes of care. So Dr. Onugha is a psychiatrist and co-founder of the Woven Clinics out in Chicago, and he traveled all the way here just for us. Appreciate it. He's a compassionate psychiatrist with a profound commitment to serving underserved populations and advancing public health initiatives. He earned his undergraduate degree in anthropology from Washington University in St. Louis in 2014, so not too far from here, and which was followed by an MD, MPH from the University of Miami, Miller School of Medicine in 2020. What a year to graduate in medicine, my goodness. He completed his psychiatry residency at Northwestern University in 2024, where he received specialized training in collaborative care models, COCM, a testament to his dedication to integrated population-level mental health care. His journey in public health began in medical school, though, where under the mentorship of Dr. Tooks, did I say that right? Okay. Dr. Tooks, he co-founded a student-run clinic providing essential care for people who inject drugs. This initiative, coupled with his advocacy for the Infectious Disease Elimination Act in Florida, ignited his passion for psychiatry and highlighted the critical importance of harm reduction in improving community health outcomes. With his unique blend of psychiatric expertise, medical education, and deep understanding of population health, Dr. Onugha brings a comprehensive skill set to his role as a psychiatric consultant. We are very blessed that he has brought his experience to us in East Arkansas, who you heard on the panel earlier today. So with that, let's go ahead and welcome Dr. Onugha. You want to use that one? Okay, all right.
All right, thank you for that introduction. I really appreciate it. Can you guys hear me okay? Yeah, all right. Well, my name is Jason Onugha. I am an adult psychiatrist by training. However, I'm really a harm reductionist first. When I started medical school at University of Miami, Miller School of Medicine in 2016, I had really no idea what I wanted to do. I thought I was gonna work as an internist at that point. And then I finished my first year of medical school, and I was also pursuing a master's in public health at the same time. During that summer, we were required to do a field experience, and I was searching for what I was gonna do because I knew I was gonna stay in Miami, and I ultimately stumbled upon this opportunity to work in Florida's first ever pilot syringe exchange program that really opened my first year of medical school. And I worked there on the front lines with people who were injecting drugs, folks with opioid use disorder, providing them with supplies for safe injection, and really getting to know and hear their stories. So that was really my first introduction to mental health, behavioral health, was at the forefront doing work in the field, and that's what led me to ultimately decide to become a psychiatrist. I'm not even on my introduction slide. That's how you know I am the last presenter of the day. So I have slides, and you guys are welcome to keep looking at them as I go. I've never been known to stay on script or follow my structure, but I have always been known to be very effective and efficient at communicating information, and I think that's why they put me as the last speaker today. So the presentation is really called Integrated, it's really going over integrative care and opioid use disorder management and medication-assisted recovery, looking at different models and approaches to solving the opioid crisis that we face. Really, ultimately, I want to discuss with you and share with you all different ideas about how to approach the opioid epidemic and folks within our communities that are suffering and oftentimes are marginalized and overlooked and don't have access to life-saving interventions. So ultimately, I'm going to share a lot of ideas, a lot of different examples of models that have different strengths, but also have different weaknesses. And I want you all to think about your communities, your organizations, the patients that you work with, and really think about that lens. Because ultimately, whenever we're doing research and we're creating all of these really cool projects and collaborative care models, we have to keep the patient first. We have to always remember that it's people with lived experiences that are going to guide us and give us the tools that we need to be able to create these interventions and make things actually work. So sometimes we come up with these ideas and we forget to have those people at the table, those people as stakeholders that can really inform the work that we want to do. So if anything, please just remember that by the end of the presentation. All right, so like I said, we're going to talk a little bit about different learning objectives. I want to talk about setting the foundation of an understanding for medication-assisted recovery and harm reduction, and what does that mean? How do those things interplay together to ultimately allow for us to provide treatments to people who inject drugs and people with opioid use disorder? In addition, we're going to talk about effectiveness of different models, thinking about telehealth, the collaborative care model, and thinking about how they can be implemented to help us address the opioid epidemic and the opioid crisis that we're seeing, and think about different outcomes. We're going to talk about hybrid models, right? Approaches to really meet people where they're at that help us address these issues. And then lastly, we're going to think about the regulatory landscape and where we're at currently and historically, especially after COVID-19, and how that has really shifted a lot of the regulations that some still are in limbo for us to really deliver and think about telehealth services and collaborative care. So first off, we should do a brief overview about harm reduction and medication-assisted recovery to think about the foundation for the rest of the presentation. So opioid use disorder, right? Based off of the DSM, we think about opioid use disorder. These are folks that are struggling with addiction to opioids. We know that the drug supply predominantly, depending on where you are, is a lot of synthetic opioids like fentanyl, and how that has changed the way that we manage and support patients in these communities. We know that folks struggling and suffering from opioid use disorder have a number of medical sequelae: HIV, hepatitis C, bloodborne infections, soft skin tissue infections, endocarditis, hospitalizations, and so on and so forth. One of the things I always want us to remember is that this is an illness. Illnesses do not occur within a vacuum, but they happen in a complex interactions of biological, genetic, socio-political components that all interact together to give us these illnesses, and especially with substance use disorders, because the stigma around them is so great. I'm going to skip that slide because I don't know why it was there. So recently I wanted to talk about contextualizing the epidemiology of the current opioid epidemic, right? Recently we heard in the news from the CDC that we have actually started to see a decrease and a decline in overdose fatalities, which is the first time that we've seen that since 2020. Really, we have been seeing an increasing and escalating rise in overdose fatalities over the years, and I'm going to give you guys a little bit of a historic perspective in a minute here to just see how we got to this point. But this was good news, right? At the same time, I don't want us to think because we have seen a brief glimpse in this cross-sectional space of 1 year, a decrease in overdose deaths, that the problem is solved. Right? This is still the leading cause of death for adults, 18 to about 40, is still overdose fatalities. So there's still a lot of work to be done, and as there's shifting changes in our medical landscape, in our healthcare landscape, we really have to be thoughtful and intentional about how we can continue doing this work and hopefully continue to produce a decrease for a very, very significant degree of mortality and morbidity that we see from opioid use. So this is the historic perspective that I wanted to share with you. Also, can I take this out? All right, I don't think I could stand in that same place the whole time. So one of the first things I want to talk about is the first wave of the opioid epidemic that started here in the 90s, where you start seeing an increase in overdose deaths, right? A lot of you have probably heard the narrative and the stories and the situation with pharmaceutical companies and the overprescription of opioids and how that resulted in this really escalating initiation of this epidemic. Then in the 2010s, you start to see this increased use and overdose deaths related to the rise of heroin. And a lot of that does have to do with things that we did from a political and legislative approach to decrease the access to prescription opioids, because we started to realize that they do cause addiction, despite what some people may have said. But ultimately, that made a transition to heroin and to illicit substances, and you see a rise in opioid deaths. After that, you start to see the rise of synthetic opioids, fentanyl, which a lot of the drug supply at this point is fentanyl. You'll talk to folks who have been using heroin for decades that are starting to lose their lives because of how potent this medication is and just how deadly it can be. All right, so the next thing I want to do is provide you all an overview of medication-assisted recovery and how that fits into the harm reduction framework. Harm reduction, like Dr. Ward-Jones said earlier, is meeting people where they're at. It's not just one intervention, but it is a collection of ideology grounded in social justice, grounded in compassion and humanism for folks who have been marginalized and oftentimes underserved in our communities. Different components of harm reduction include things like syringe exchange programs, housing first programs, things like medication-assisted recovery that includes medications such as buprenorphine or Suboxone oftentimes, methadone, and naltrexone, which are the 3 FDA-approved medications for us to treat opioid use disorder. So at the end of the day, that's only one piece, but we know that things like Suboxone and buprenorphine significantly decrease folks' mortality from overdose and can be a life-saving and life-altering intervention in people's recovery journey. Oh, back to the computer I go. Oh, perfect. So, what are the benefits for medication-assisted recovery? Right, one of the things that I talked about in highlighting the opioid epidemic in the fatalities related to overdose, and that's one of the things that buprenorphine and medications like methadone and naltrexone can really help folks with. It can act as a protective barrier in people's recovery journey to decrease their risk of overdose and help them reduce their harm related to their substance use. Other things that you see are public health outcomes. Harm reduction approaches and medication-assisted recovery can help folks decrease their use and oftentimes lead to mitigating and preventing some of the other outcomes that I talked about earlier as well. All right. This is jumping around very quickly on me. Okay, so the barriers that you see in terms of addressing opioid use disorder and treatment are a lot. So we know that this is a major problem, but we also see that people are having trouble accessing these services, right? We know that 1 in 5 folks with opioid use disorder were actually able to access medication-assisted recovery, right? And there's over 1.2 million folks with opioid use disorder. That means only 20% of them are getting actual treatment in their communities and are continuing to suffer and ultimately may lose their lives from overdose. So what are those barriers, right? So there are really different major things that we're seeing in barriers and why folks are not able to access medication-assisted recovery and harm reduction services. One of those things is at the provider level. When we talk about opioid use disorder and we talk about substance use, there's just a significant amount of stigma that comes from it within the community at large, but also within the healthcare community. Even more focused in the behavioral health community. We often see the siloing of physical health and mental health, but then even furthermore, you see the siloing of mental health and substance use. And that's one of the reasons I really enjoy being in these spaces with you all, is that we're talking about integration. We're talking about whole person health. We're talking about not ignoring some of the reasons that people are suffering and being able to address those in a way that is effective. From the provider level and individual level, then we're talking about knowledge. Folks don't know what they don't know, or sometimes we choose to ignore it. So there are providers who don't have the ability to be prescribers for Suboxone because they don't want to because of stigma, but maybe because they don't feel well supported and have the ability to be able to prescribe those things with confidence and support their patients through the recovery process. Other barriers to care include regulatory barriers, institutional barriers, regulations that we saw rapidly change within the COVID-19 public health emergency, ultimately led to a rapid utilization of services like telehealth, which significantly changed the landscape, and we're going to talk about in a little bit, for the delivery of medications for opioid use disorder. All right. So this map is a graphic that I really, really like because it helps demonstrate where we're at in treatment. So this is a little bit old. This is from 2016, but this shows all the substance use facilities in the United States where there is access to at least one medication. I told you there were 3 earlier, but it shows just where you can get at least, this facility offers one modality for medications for opioid use disorder. So this graph here then only focuses on locations where they're offered at least 2 forms of that treatment. So either methadone, buprenorphine, or naltrexone. And then when you go to this slide here, you can see that this represents all of the substance use facilities in the United States where all 3 modalities are offered. So thinking about the different medications for opioid use disorder that I briefly mentioned, there are clinical reasons why one would be more favorable over the other. There are also logistical reasons. For instance, methadone requires you to go to a specific facility, wait in line, and there are significant barriers to be able to go in to do that on a daily basis, right? Some people are not appropriate for methadone because maybe they have prolonged QTC and cardiac issues that make them not viable for that medication. So if they go somewhere, what are they to do next if these facilities don't all have them? So it's important to think about meeting people where they're at and understanding that there is a significant barrier to access that is resultant from institutional, organizational, and regulatory issues, as well as provider level challenges. All right, so we're going to talk about advancements and challenges within telemedication-assisted recovery models and how we can utilize some of those things in order to help improve access to care for medication-assisted recovery. So what is telebehavioral health? So a lot of you use it. It's something that's come into existence, and like I mentioned, after COVID, we started seeing a significant uptick out of necessity for the utilization of telebehavioral health, which you can see defined here is the utilization of telecommunication technologies to engage in patient care directly. So, thinking about the regulatory landscape for medications of opioid use disorder and telehealth and how that significantly changed during the COVID-19 public health emergency that started here in March of 2020, which was also the same time that I started medical school, so seeing all these changes really take place during my training years, when I started my residency, was very interesting to see how that changed how we approached care. So a lot of things changed within regulations. You know, in 2008, you had the Ryan-Haidt Act, which limited the ability to prescribe controlled substances by providers without an in-person visit. This was also relaxed during that time to allow for us to engage. There were changes in CMS requirements for locations of patients that typically before had to be at specific sites for us to be able to engage and do telehealth services. That was also relaxed. So a lot of these changes in terms of how we managed payments for telehealth services, the limitations and requirements that we saw allowing for the use of telehealth and medication-assisted recovery allowed for us to start to see, well, how is this going to impact the delivery of medications for opioid use disorder? And would it make it more viable? Would it make it more accessible? And this is something we're going to explore a little bit further. So, what are some of the benefits of telemedication-assisted recovery? Well, accessibility, right? Ease of access. Folks that, as I showed you earlier, don't have a facility around them that offers those treatments, where do they go? This now extends the reach to places that don't have providers, where it might take you 75 miles, 100 miles to your nearest buprenorphine provider, and now you're able to go and easily access this person. You know, locations where there aren't addiction medicine specialists, how do you go about reaching them or integrating them into your programs? And now telehealth has made that significantly easier to do and consider utilizing resources across larger areas. So, telemedicine in substance use treatment pre-COVID. So this is pretty interesting to me. We talked about stigma and we talked about the separation between behavioral health and substance use. So this is actually before you started seeing these changes, and you really did have a rise in the utilization of telemental health services even before the COVID-19 pandemic. But then if you look at the line below on this graph, which is this green line, you'll see that this is telesubstance use disorders. And I think the graph really speaks for itself and shows that there is a significant disparity between how we utilize telehealth services for mental health and how we used it for substance use. A lot of that does have to do with some of those regulatory constraints, such as the Ryan-Haidt Act that required folks to have in-person visits for the prescribing of controlled substances. So this is another study here. This was done in the VA system, and it really looked at the change in utilization of telehealth services for buprenorphine right at the time of the COVID-19 public health emergency. If you look at that dotted line straight down this graph, you'll see that in-person visits, obviously as a result of COVID, significantly plummeted. And in that orange line, you'll see that there was a significant rise in audio utilization of services, and then video was also on the uptick during that time period as well. It's really interesting because when we were looking at the overall healthcare landscape, you saw a decreased utilization of health services, but actually for buprenorphine, you started to see a significant rise in those things during that time period, suggesting that maybe telehealth and these relaxation of circumstances allowed for us to increase access to care. One of the things that we have to think about with telehealth and be very careful of is, despite all of the possible benefits that I mentioned and how it can be transformative, is does that mean it's transformative for everyone? Is telehealth delivered in an equitable fashion where it's easy for everyone to access? And we're going to talk a little bit about the data around that in a minute. So when we think about telehealth, we also need to think about the challenges and how there might be disparities that arise if we're not intentional and thoughtful about how we create and build these programs. That there might be communities and populations that don't readily have access to consistent Wi-Fi. That there are populations where having a phone isn't something that's guaranteed as much as we think it is these days. That there are populations that might have limitations physically or mentally that have trouble navigating some of these sign-ins. I've done outpatient care and I've done a lot of telehealth, and I've made phone calls and tried to walk some of my patients through how to sign into their visits. And then I'm halfway through the call and I don't have time to really do the encounter. So that's something that we really have to be thoughtful about when we're creating these programs and thinking that telehealth might be a end-all be-all, but it's really not something that we can do without thinking about it in a nuanced fashion. So what are these potential challenges? You know, quality of care folks are thinking of, will that decrease? A lot of the studies demonstrate that you're actually really having positive outcomes. I think some of the things that I mentioned just now in terms of groups that might have limited access, even though these are the people that we're trying to increase access for, is something to really consider. So, one of the studies that I found very interesting was comparing the utilization of telemedicine during this COVID-19 period, and it was a retrospective study really wanting to understand who is utilizing in-person versus telehealth services, which I think is really important to making sure as we build these programs, or you think about your organizations, how are we going to utilize this technology to increase access, and who might be vulnerable to not receiving care through these modalities. So one of the things that I found really interesting here was that they looked at the homeless population. Homeless population was actually statistically significantly more likely to do in-person visits, right? And that might speak to, as you kind of engage in these programmatic designs, you really want to engage those people with lived experiences to think about what does make sense for you, what will help you, right? And if we don't engage in those conversations, you're going to really ultimately struggle to implement programs and solutions that are really equitable and increase access effectively. You also see that, you know, folks in urban settings as well had a significantly different experience compared to those with rural. So, who is and who is not receiving telemedicine care during the COVID-19 pandemic? So I did mention this as one of the things that we really do need to consider, is that there is a difference in folks who are using telemedicine services based off of age as well as socioeconomic status. You saw that folks were in areas that had significantly lower levels of poverty utilized telemedicine services more frequently. So when we think about how we create and utilize telemedicine services to support the delivery of medications for opioid use disorder, we also want to make sure that we're not increasing the disparity gap even further. So what are some future directions in terms of delivery of telemedications for opioid use disorder? We do need to continue doing research in this space because we want to be intentional about our designs. A lot of the studies currently are limited to short periods of time where we're looking at retention and treatment at 3 months and maybe 6 months, and we really want to get a better understanding of how folks are engaging in this use. I do think that the current data does suggest that telehealth is a very viable solution to delivery to some of the challenges that we're seeing in access for medications for assisted treatment. So, other models, in addition to telemedicine, when we're thinking about medication-assisted recovery, and we're going to talk a little bit about the collaborative care model. And this is where I'm very lucky because you guys have gone through this entire day and have heard about this model and this structure, so I do not have to do too much reiteration. But this is a population-based evidence approach to behavioral health integration that has multiple components that, when initiated with high fidelity, can result in significant improvement in outcomes and increase access to care. Fair summary? Okay, we're going to keep going. So, a lot of the studies really focus on mild to moderate disease and focus on depression and anxiety. There was a trial called the TRAMP trial, the CHAMP study, that wanted to say, well, is COCM an effective model of care for opioid use disorder? Which, when I saw this study, I was like, great, love that. Is this going to be a way that we can really change the narrative about access to care for opioid use disorder? So what were the key findings? When they went out and designed this study and implemented it, and there are the challenges that I believe that a lot of this, some of this occurred during COVID, was that a lot of the patients that were coming into treatment within these primary care clinics that were part of this trial were already on maintenance treatment. And one of their major goals for this program was to have something where they were able to help initiate patients into treatment. So there wasn't a lot of uptake as they thought that they might find initially when they started this program. So recruitment was a challenge, and ultimately they were thinking, are the patients even in these spaces? I think when we think about collaborative care models and we think about implementing and creating this type of structure for people with opioid use disorder, you have to start with the people themselves and the spaces that we're in. Where we know that opioid use disorder is oftentimes incredibly stigmatized, and folks with these lived experience can internalize this stigma, so are they presenting to the primary care settings in the first place? We know that these patients really do struggle, and these patients can be in those settings, but we really want to know, based off your own organizational experience and data, have we created environments where folks with these experience and with these challenges feel comfortable to engage in that care? And I think that can really change whether or not this strategy is a viable approach. And I talked about that. All right, so thinking about additional approaches for integrative care for medication-assisted recovery outside of telehealth and outside of the collaborative care model, I think is really important. So we talked about how that telehealth can really be a strong approach to increasing access to care, but there are limitations to consider. And we also talked about the collaborative care model, which you guys have heard so much about today, and how there are also limitations when we're thinking about primary care settings and how we can make sure that the folks that we're trying to meet are where they are. So I also wanted to think about other approaches and other ways that we can engage in models to help increase access to care. One of the approaches is a hybrid approach to tele-harm reduction in the delivery of medication-assisted recovery. This study was conducted in Miami, Florida, where they implemented a peer-directed, a peer-supported, and approach to the delivery of medication-assisted recovery, where people who injected drugs would present to the syringe exchange program, would have peer supports there, and if they felt ready, that there was an on-demand telehealth service that they could be met wherever they were. So maybe someone came into the mobile van to exchange their syringes that day, and they said, hey, I think I'm ready, and they were able to get the patient on with a provider and allow for them to do that appointment to do an induction into buprenorphine. That there is an approach that would not have been able to occur if we didn't have all of those regulatory changes that occurred during COVID-19. A lot of those changes, are not firmly in place at this time, and you continue to see extensions of some of those regulatory changes, but we continue to await kind of final stances and guidance on that to help us understand how we're going to do the work going forward. But when we look at this study, you saw that in a 3-month period that there was a significant retention in treatment, I think around 58%. Other spaces that we really want to think about for medication-assisted recovery integration is the emergency department. We think about, like I said, harm reduction in the approaches, which to me is the foundation of integration, is meeting people where they are. That people with opioid use disorder and substance use disorder are often going to emergency care centers as a last resort. And oftentimes they don't even want to go there, but their situation just has become so dire that they feel they have to present in order to get that support and the treatment, or they're presenting after an overdose and the administration of naloxone within the field, and they're presenting to the emergency department after that. So this is an excellent opportunity to think about, well, how are we using these services, right? It's an excellent opportunity to think about, well, how can we partner with our local hospital systems and our emergency departments that are seeing these people on a constant basis and utilization of resources without really a change in their outcomes. So the emergency department has demonstrated through some studies, as looked at as a place where you can really implement integrative approaches to medication-assisted recovery, where you can do inductions in the emergency department with Suboxone, studies demonstrating engagement in an administration of Sublocade or long-acting injectable versions of buprenorphine, helping to reduce the likelihood of overdose in the future for patients. We think about bridge clinics and connecting those to emergency departments, allowing for programs that help with treatment after the emergency department to really think about breaking that cycle. And I think when you think about the economic and financial nature of emergency departments and hospital systems, there is incentive for those groups to think about how can we support these patients and decrease the sequelae that ultimately end up being very costly to the system. So things like endocarditis and things that patients struggle with injection drug use ultimately because they're untreated and don't have the proper support within the community. Some of the challenges and considerations to think about when implementing emergency integrative approaches to medication-assisted recovery have to do with getting buy-in. You know, you heard about buy-in during the panel about collaborative care. I think it's true for any integrative approach that changes the way that we work. So when you're thinking about how can you create these partnerships, it's important to have folks that are champions within those space, have folks that really can get behind and understand the nuances and meet people in a compassionate manner. One of the last ways that I want to talk about are alternatives. And for folks that are working in places that are under-resourced, that don't have the ability to start with some of these large programmatic shifts, are there small steps or incremental steps that we can take to help increase access to medication-assisted recovery? Maybe it is a primary care clinic that has a large population of people who have opioid use disorder that don't have the capacity currently to implement something like the collaborative care program. There have also been studies looking at educational and administrative support approaches to help educate providers about medication-assisted recovery. One of the regulatory changes that I forgot to mention was that, you know, there's no longer the requirement for a data waiver to prescribe buprenorphine. And even with that, we still don't have a high number of buprenorphine prescribers. That could be related to bias and stigma, that it could also be related to a lack of educational support and feeling how can we actually go about introducing these type of treatment plans effectively. There's also been some studies looking at kind of a consultative models to help directly engage addiction specialists and psychiatrists with primary care to help them walk them through induction processes with additional support from other providers as well. So again, some of the challenges when we think about this is, again, rural areas having access to some of these services, and then thinking about how we can utilize kind of these hybrid approaches to help engage these communities and these folks that are struggling with opioid use disorder as well. Oh, well, questions? Yes. I can hear you. Yeah, I think it's important to start conversations, and that is a challenge. I know that there is kind of an approach that's either abstinence and medication-assisted recovery can be looked at as not part of that continuum. For me, I think about how I compare it to any medical challenge, right? Folks with diabetes and chronic illness that struggle with nutrition status, you know, it's very similar in terms of how we need to approach and support them. I would never say that insulin is not a part of the treatment plan. I don't know how I would rectify that in my mind, that buprenorphine and other medications for assisted recovery has demonstrated significant results in decreasing overdose fatalities. Distribution of naloxone alone is something that has also helped in supporting kind of decline in overdose fatalities. The spaces in which medication-assisted recovery is not a part of that, or organizations that don't necessarily want to include that as an option, I think there's a lot of education to be done, right? That is a result of a lot of stigma, and we have to really think about how we dismantle that, right? So I think it starts with individuals and providers and engaging in organizational change, but that does take time, but it also just takes effort, which I know that a lot of folks in this room are willing and more than able to do. Hopefully that answered some of your question. Yes.
Prescribing and
Yes. I think it's important to, again, like I said, the foundation for me is in harm reduction is meeting people where they're at. And that means different things for different people. I think if we get in the weeds of turning people away and saying you have to do and being pejorative and prescriptive about the solution for someone's recovery, I think ultimately is not going to result in the most successful changes that we can see for an individual, but also on a population. So I think every door is an opportunity for change and to help someone with that. It could be in the emergency department in a brief intervention, even kind of a motivational interviewing techniques in the emergency department for short periods of time has been shown to be helpful for folks. And buprenorphine given is really important because if people have come out of periods of time where they haven't been using, they're also more susceptible to overdose during that time, right? So we really have to think about, are we reducing the harm that is potentially occurring for these patients? Great question.
I have a question. So to her point about Suboxone, it's a really sympathetic instance that I see a lot in my therapy office is someone with a legitimate kind of chronic pain who gets caught up in addiction after an injury on the job, something like that, and then they find Suboxone, or they find themselves getting pills off the streets, and then Suboxone is offered as an answer, and then it's successful. And the idea is that, titrating down and eliminating it, and oftentimes my clients don't want to get off it because, well, it solves the pain issue, but so the addiction is still there. And I'm just curious your thoughts on how the provider should kind of handle such kind of long-term Suboxone use. What is the route? Is it harm reduction to not let them go back? Because the pain will still remain, right? And so there's a catch-22 here, I think.
I absolutely love that question. I think that substance use disorders, opioid use disorder, these are chronic conditions, right? And when we think about chronic conditions, we know that that means that there might be periods of relapse, right? And doing substance use work, the natural history of substance use disorders is folks may go through periods of time that could be instigated by socioeconomic crisis, interpersonal conflict, where relapse might occur, right? So for me, it's really that engagement one-on-one with patients, right? Some of the, not some of, but a good amount of opioid use disorder is iatrogenic in nature. That, as physicians, as providers, that there is a role that we're balancing, addressing chronic pain and management of opioid use disorder, which becomes tricky at times. But I think really thinking about patient-centered care, where are they at? If a patient wants to try to come down on their Suboxone and trial off of it, do we provide them with appropriate resources to help them be successful? Or if it's working and they're able to function well and decrease their risk, right? Having conversations about what are the risks of this option versus the risk of that option, and again, giving that power to the patient, right? I think the answer is not going to be the same for everyone, but we really do need to take an approach that is team-based and patient-centered and dealing with those really nuanced issues that can come up in treating folks with substance use disorders in general.
Those are great points. I have a quick
Nothing
question.
to add. What?
I have a question, which is you talked a little bit about substance misuse. There are medications available. Teach healthcare professionals this is a chronic disease? Are we teaching medical professionals and behavioral health professionals? And if not, do you think that's a needed component to change the culture of how we're looking at substance misuse?
Yeah, I think education is a huge part of us making a transition, right? Education and integrative care approaches, education and how we're looking at and addressing substance use disorders really needs to change, right? Even the language about how we utilize it can really be pejorative or really place blame on individuals instead of focusing on whole health and individual care. You know, as I do teach and work with residents and medical students, so I hope and I try to engage them in some of those conversations and really teach an approach that is patient-centric to addressing opioid use disorder and understanding it as chronic illness. Well, I really appreciate you all. If there are any questions or just considerations or people ever want to talk about integrative care and medication-assisted recovery, I always like to have those talks and learn more from other folks. So feel free to email me or reach out. But I appreciate y'all's attention throughout this talk.